Thank you very much. My next talk is about whether we're getting better at what we do, or are the results of our surgery improving as regards revision rates, which are not, of course, entirely the same thing, as revision is not the only important thing in how well we do our work. I'm very grateful to Adrian Sayers, Kevin Deere, and Eric Lengerand for preparing the information and the slides for me for much of this talk. So where did this problem arise, and why did we feel that there was an important area of discussion here? First of all, the Swedish total knee data from the Swedish registry some 20 years ago showed that over 5-year periods from the start of when they started to do knee and unicompartmental replacements, the results varied considerably. And each 5 years for total knee replacement, their results improved dramatically during that first 25-year period. Whereas for unicompartmental knees, as you can see on the right, the results did not really improve that significantly. Although it's important to recognize that the numbers were very different. Initially, there were fewer total knees than unis, and they grew disproportionately. So at the end, there were 4 times as many total knees as unis. So there is a clear cohort effect here, but it's not clear whether the cohort effect was caused by the passage of time, by a learning curve, or by the fact that there was a very different way in which the numbers changed. So what is a cohort effect? Well, this is a variation in outcomes which may change with respect to time, and it can be due to many different things, including different populations, the practice of surgeons, the unit organization, different implants, and changes in the data capture. When investigating a cohort effect, since it's time-related, you can start all of these curves at the same point on 0, and they then extend for different lengths of time. But of course, although this is what they did in Sweden, they did it for only 5-year periods, whereas we have so many more patients in the NJR that it would be very reasonable to look at each year by itself. And you can see that if you do that, by the time you have 16 lines, they're all overlapping and are very difficult to really follow. There is a different way of looking at it. You can start each line on the year itself and finish them all on the same year, i.e. the current year, 2020. And you can then plot differentially the landmarks for 1 year, 3 year, 5, 7, and 10 and 13-year revision rates. And those are what then appear as these red dotted lines. And you can see that in that way, you're able to follow what happens, both with the passage of time and for each year cohort. But what do these charts mean? Well, if you look at a static cohort with no change in failure with time, you can see here with data which is simulated that you would get a completely parallel set of lines with increased revision rate between 1, 3, 5, and 7 years, but no increase in those during the passage of time. If you instead have data which shows a 10% annual reduction in failure, you can see that this causes these curves to slowly decline or improve towards the baseline and get closer to one another. Whereas if you instead have a 10% simulated increase in revision rate, the curves are no longer parallel again, but they are climbing rather than diminishing. Of course, real data is much more complex, and you can see here the real hip data, which you've already had a look at, and you can see that there are fluctuations with time, and they peak here, 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 and here. We, of course, have many joints and we have many options for the different joints. And it's clear from our own data and from the Swedish data that it would be important to look at different implant choices and at different types of hip and knee replacement. So we can look at these variations according to fixation or the types of replacement. So looking at hips, we first look at all total hip replacements bunched together. And you can see with the simple lines starting from each year, you can see that initially the lines bunch together and become steeper, and then after about 2008 they separate out and they bunch together, becoming more shallow and closer to the baseline. If you look at the red dotted lines that we showed before, you can see very clearly how these change with time, but it's a bit more difficult to see exactly which year the cohorts are getting better and which years the cohorts are getting worse. So by overlapping the two groups of lines, you can then get this much better picture, and you can see 2008 is a pale grey line, and that pretty much coincides with the peak for each of these curves. At the top, of course, we don't see a peak for the 13 and 15-year results, and the reason for that is obvious. We don't have 13 and 15-year results for those people who had their operation done less than 10 years ago. So we don't yet see a drop until we have the bulk of those patients beyond 13 and 15 years. If you look instead at resurfacing, again, you see that there is a cohort effect with peaks, that the results were getting worse and then they started to get better. And by 2011, when the ASR data came out in a big way, and when people started to make a considerable noise about whether we should be doing metal on metal hips or resurfacing, you can see that already the results had improved dramatically. That green line shows that year. And you can see for several years before that, the 3, 5, and 7-year results were already improving. What was this? Was it better patient selection? Was it general improvement in surgeons' experience? Or was it a combination of those things? You can see if we look at stemmed metal on metal, the result is very similar, although towards the end of the graphs, we were doing so few that in the bottom right-hand corner, we can no longer see a consistent or coherent drop, because by that time we were doing so few that one single failure causes a massive change in the revision rate. If we exclude all metal on metal, we might expect all of these peaks and troughs to go away and to have a consistent failure rate. But in fact, you see that even then, from around 2008 in most of these curves, you can still see that there is a persistent improvement and downslope to the lines towards the right-hand side. If you look at cemented hips, there's even less change, although some of the curves show a slight downwards drift. By and large, these are largely parallel lines, and therefore the revision rate could be said to be static over the last 15 years or so. If we look at uncemented total hips, there is actually some steady downward slope of these curves, which suggests that the results are improving, although we can't tell whether they're improving out to 13 and 15 years with very much confidence at present. Hybrid hips, as one might expect, the revision rates fluctuate slightly between those of cemented and cementless. And bear in mind throughout that there has been a substantial change in the proportion of these types of hip replacement that we've been doing over the years. So how do we fare with knees? Well, we might think that the knee replacement data would be different because there's no metal on metal issue, but you can see that again, from the grey line around 2008, there is a steady improvement in 3, 5, and 7-year results. If we look instead at the total knee replacements where the patella has been resurfaced, again, you see a moderate reduction in the revision rate since 2008 at nearly all the time landmarks. Similarly, if you don't resurface the patella at the time of your primary operation, there is a steady, gradual, albeit small improvement in revision rate since 2008. And bear in mind that in the UK, probably 60% of total knees have been done without resurfacing the patella at the primary operation for the last 15 years. Interestingly, if we look at unicompartmental knees, there is a dramatic difference between our data and the Swedish data published years ago. There is a strong reduction in the revision rate across time, and this started almost immediately in about 2004 and has improved ever since for all time points. This extends for all total knee replacements, even up to the 13-year revision results. If we look at cemented knees, again, with the unicompartmental cemented, there is a clear cohort effect with an improvement across time scales of 3 to 13 years. If you look at the uncemented unicompartmental knees, the data are a little bit more erratic. The initial data were based on small numbers, those shown in blue below, and nevertheless, after an initial increase for a year or so in the revision rate, you can see that there's a steady improvement up to the 7-year results. The 10-year results are really not clear yet because they went up for the first year and down for the second year. We may see an improved cohort effect at 10 years in due course, but we'll need to follow them for another 2 or 3 years before we can find that out. Hybrid unicompartmental knees are not done in such large numbers, but nevertheless, the results do seem to have been steadily improving, albeit the confidence intervals being very wide. Patellofemoral replacements are done in rather larger numbers than those, and you can see that there really doesn't appear to be a consistent improvement across the board. Most of these lines are fairly much slightly up and down or parallel with one another. And again, knee replacements have not changed in the way that we major on cemented or uncemented or unis, although the unicompartmental rate is increasing for the last few years. Shoulder replacements are, of course, done in much smaller numbers, but we have some data. You can see for all elective shoulders bundled together, the revision rates have not been improving significantly, really. If you look at hemiarthroplasty, again, there is more or less a series of parallel dotted lines, but perhaps there may be a slight increase in revision rates at the end of the 3 and 5 year curves. If you look at conventional total shoulder replacements, the 1-year results are perhaps falling consistently for the last 5 years, but not a great deal, and the 3-year and 5-year results are really not easy to interpret. If you look at the reverse shoulder total replacements, then there is some improvement, and these are based on much larger numbers than some of the others, so that may be real and with less noise in the system. But reverse shoulder can be used with or without a cuff tear. If you look at the patients who do have a cuff tear, the revision rate hasn't really changed a great deal. If you look at the reverse total shoulders without a cuff tear, there has been an improvement in the results in the last few years. If you look at total elbow replacements, then you can see that the total elbow replacements are done in much fewer numbers, and therefore the curves are much more unreliable and the confidence intervals are much greater. The 1-year results do appear to be fairly static. The 3-year rates are more variable, and it remains to be seen whether by 3 or 4 years' time we will have sufficient numbers to be able to make a clear prediction about whether the trend is upwards or downwards. Total ankle replacements are done in slightly larger numbers, and if you look here, you can see that there is a slight tendency to think that the 1-year results may have gone up and then come down again along the same lines that we saw with hips and knees. If that's the case, then perhaps there's a reflection of the same sort of thing happening in the 3-year results, but the 5-year and the 7-year results don't have sufficient points on them yet to be able to tell whether that's going to happen to them in the future or whether the results 5 and 7 years are actually deteriorating. So in conclusion, we can say that there's good evidence for improving revision rates for many of the arthroplasty types over the last decade or so. This applies for hips and knees, and for hips even when such problems as metal on metal are excluded. Unicompartmental knees, interestingly, seem to show the most obvious improvement in revision rates with time over the last decade or so. There may be many reasons contributing to these changes in the revision rates. Some of them are to do with the subdivision into types of joint, but some of them may be due to other factors such as how we use them, who we select, and a combination of different factors. Thank you for your